Ladies and gentlemen, good morning. And any of you who aren't either ladies or gentlemen, welcome. Gosh, that worked well, didn't it? Apparently I have to stand here, otherwise the camera can't see me. My plan for this week was to hand it over complete control to Peter Kavalek and to sit at the back and heckle with the rest of you. Unfortunately, Peter phoned last night to say some of the weather that Brian had ordered for the railways has escaped into Peter's basement. So he currently has a home swimming pool. He'll be with us a little later in the day. So if you don't know me, I'm John Beckford. I think most of you do. I don't see a face I don't recognise, which is either good or bad. I'm never sure which. And welcome to the Cybernetics conversation. We'll do the important bit first. In the event of a landing on water, there are emergency exits there and there. So follow somebody who's an inmate because they will find the fastest way out. The loos are across the kitchen, as you probably discovered, and there is apparently a fire alarm test at 3 o'clock. So we need to just remember that that might happen in the middle of whatever we happen to be doing at 3 o'clock this afternoon. But other than that, lunch is ordered and we'll turn up at an appropriate point. We want to be as informal as we can be, despite the fact that we're doing things a little more formally than last year. This is the second of these things we're calling the Cybernetics conversation, and the idea is that you contribute at least as much, if not more, than the various people that we put in front of you who will actually irritate or stimulate your thinking. This is what we're going to do over the next 3 days. So today we're mainly talking about health and social infrastructures. We've got two speakers, two provocations from Charles House and Chris Murray on those themes, and then much of the rest of the morning we'll be debating what they had to say, and then Duncan Cole will stimulate us again after lunch with something fresh. Tomorrow we're going to look at the hard infrastructure, the railways that didn't get us here on time and all that sort of stuff, and that's Arup across the road. And on Wednesday, mainly I think inmates, members of the society getting together to talk about what we should educate people in cybernetics. Okay, have to move that. Okay, so that's welcome, and thank you to Charles and Chris, who will join us shortly, for hosting us here today, and to Nusrat and Carla for getting the facilities ready and all the rest of it. Really, really important. Otherwise, we wouldn't be here. Protocol: we are recording what is being said, at least by me and other speakers, and we'll make those recordings available on YouTube. We won't be recording the individual conversations on the desks, other than the extent to which you write stuff down to remind you what to say when you're asked to give feedback, Dr. Dewhurst and Dr. Dudley, at various points of the day, just so you're warned in advance. As I apologies from Peter, who will be here as soon as the trains permit. Okay. Purpose, why we're here. Everything about cybernetics is purposeful, otherwise not really cybernetic, is it? What we're trying to do in some respects is to bring the world outside cybernetics into the world inside cybernetics, so that people who are not so familiar with the territory of the society can be exposed to it, but also to expose the society to the needs, challenges, opportunities that exist in the wider world around us. Because any science, any discipline is fairly useless if the practitioners keep it all to themselves. And given that we all spend an awful lot of time talking about this stuff, maybe it's a useful idea to share it with others. So, to some extent, we make it up as we go along. Yes, Thomas? I'm too tall, is the problem. Let's adjust the camera slightly, can we?
John's doing that. If anybody's not done a name badge, please do a name badge and pop it on.
Yes, Dr. Haddock.
Where are they? Over on the table. Yeah.
Okay. Say that again, Brian.
I would expect it to run out of camera.
It's not my camera. Okay, I'll stand closer to the wall, which sadly makes it hard to move around and be it's harder to hit a moving target, isn't it? Okay, we'll try. The thread that I sort of thought we should put together is this: society, this thing to which I think we all belong, kind of emerges from a set of fundamental infrastructures around energy, transport, ICT, water, and waste, which are all in dynamic interaction, and their existence enables the society that we live in, healthcare, education, commerce, civil administration, even defence, to exist. So we have this sort of loop going on. You don't have to draw pictures of the slides, just ask me for them later.
Carry on, Tom.
No. Sorry.
No, sorry.
We'll give you we'll give you copies of the slides later, don't worry, not a problem. That's okay. So we have fundamental infrastructure. Societal infrastructure rides on the back of that, and the thing that we recognize as society emerges from it. But if society then creates demand on the social infrastructure, which creates demand on the physical infrastructure. So the whole thing loops together. Yes, Daniel?
Where do you put money?
You don't. Money is an irrelevance, you'll be pleased to hear. It's an enabling device that sits behind the infrastructures, but has no value on its own. We'll debate that one later. Okay, so the core idea of cybernetics, for me, at least as a practitioner, is that we think about the world as self-regulating, adaptive, stable, and learning. But the stability and the learning and adaptation actually come from its dynamism. They're not inherent in the bits, they're inherent in the interactions between things. And complexity emerges from the interactions between things. And the way we choose to represent that is this simple thing called a homeostat, which basically says we have some inputs, we apply some effort to those inputs, and we get some outputs. We reflect on whether the output was the one that we wanted. Did we get what we wanted? And we take action to close the gap between what we got and what we wanted. Very, very simple. Now, whether that's a thermostat keeping the temperature right in this room, a light meter of some sort regulating whatever, doesn't really matter. Or an organization acting as a hospital or a provider of some sort of civil infrastructure that either succeeds or fails in delivering the outcome to its users, its customers, its clients that it intends to. And the task of management is to try and make that happen, to try and close the gap. And it all exists in this peculiar thing that we call an environment. I'm doing this very quickly just to try and get us off to a good start. As organizers, as managers of things, as managers of systems, the thing that we're trying to do is make sure that the organization is still there doing its thing tomorrow. So we have to answer 3 questions in real time. And I give credit to Pete Dudley for this bit. He's sitting at the back, ugly bloke in a cardigan. If anyone wants to argue with him about it later. But when Peter wrote his PhD some years ago, he invented a thing called the trialogue, which is a metasystemic view of organization that says there are 3 things that we have to do in order to make the organization itself sustainable. We have to manage the present. We have to do what we're doing as well as we can. We have to create tomorrow. We have to invent the future that we want to have. And you can imagine there's tension between those 2 things. And we resolve that tension by reference to our identity or purpose, the reason we're doing things. So we're asking those 3 questions simultaneously. Okay, so I'll give credit to people. And hanging on the back of this are various systems methodologies that you can apply to trying to solve those problems. What we end up with is a bit more like this. This what I call allostatic organization. The medics in the room will be familiar with the notion of allostasis, a dynamic stability. If we freeze it, it dies. If we lock it up, it becomes sclerotic and chokes on its own vomit. We need to manage things so that they keep moving. So over here, another version of Pete's trialogue, enabling value, generating value, fulfilling purpose. And sitting in the middle is information. Information is the thing that lets it lock together. Okay, so I'm almost ready and finished. What we end up with is a day like today, which is about the cybernetics of cybernetics, where we are looking at what we're doing, reflecting on it, talking together, exploring not just where the theory might go, but where the practice might go. So practice and theory interact with each other to great effect. Okay. That was what Peter was going to say, but I'm not going to repeat all that, because I have no idea what went with the words they wrote down. A picture of today, very quickly. I'm just about in, I'm on time as well. I'm going to introduce you to Charles House very shortly, who's going to talk about challenges in healthcare, followed very rapidly by Chris Murray, talking about challenges in transforming cities. We will then, wherever Chris here will then guide us through picking some things to work on, and then we'll work as groups until around lunchtime-ish, where we'll share the feedback on all that, and then we'll give it another kick with Duncan after lunch back into a discussion loop and so on. And hopefully at the end of the day, Peter and David will help us reflect on the cybernetics of the things that we have been hearing. That's twice I've warned them, so they can't complain at the end. I didn't tell them in advance, can they? Okay, so that's enough from me at this point. No questions. You can badger me as much as you like during the later parts of the day. What I'd like to do now is introduce our host, Charles House. Charles and I have been friends working together for, it's actually nearly 10 years now that we have known each other, and we've collaborated on various bits of thinking, which is always good. And Charles has made the facility available to us today. If I get it right, you're the medical director of University College London Hospital. At which point, Charles House, come and grab the stage, and I'll get out of the way. Thank you.
Great. Thank you, John, for the introduction. I'll try and keep on the shot of the camera here. Let me know if I'm moving about. And thank you for the invitation to be part of the day today and to speak about it. I find it really interesting the way of thinking about the way that healthcare plays into society and the way that you've mentioned, John. And as John said, he and I have worked together, thought together for a number of years now about some of the challenges facing healthcare and about how to apply some of the principles of cybernetics to addressing some of those challenges. And I've been medical director at University College London Hospital for about 6 years. There are 3 of us as medical directors, each taking care of one of the clinical boards. It's a big organisation, so we've sort of chunked it up 3 ways, and each of us run one of those clinical boards. And I'm happy to talk more later about how that works and what I'm responsible for. So people often ask me, what's your biggest issue at the moment? What's the biggest challenge facing the delivery of care? And of course you can say, well, how long have you got? And I'll talk about some of the challenges facing us. But I think that my current answer and my answer for the last 12 months or so has been workforce, and has been about managing to identify, to train, to recruit and retain enough people to deliver the healthcare that we're seeking to deliver. So there are lots of issues sitting behind that. Whether you think, well, for years we haven't been training enough doctors and nurses, or whether you think the issue is around more around retention of the number of doctors that we train, how many we retain in the profession. Perhaps you think that the main issue behind the drivers of the problems that we face in workforce are around migration and around the difficulties in recruitment which have been put in place in recent years. Maybe you've been watching the news, maybe you think that the issue is around how much we pay doctors and nurses and whether we make it attractive enough or not. And perhaps there's still something, certainly, about the pandemic and about an exhaustion of the workforce and about how we manage to rehabilitate that workforce and enable them to recover from several years which have significantly physically and mentally left them drained, and has made a bit of a quantum shift in thinking about how we provide care. So workforce is my major answer to that question at the moment of the challenges facing healthcare. But you can never overlook the money, and the money may well be the biggest issue. As you know, in the UK, we spend relatively little on healthcare compared with other countries, which is not to say that we don't provide good care. We do, but we focus very much on efficiency. And of course, the population is changing. We have an older population than we've had in previous decades, and we have people therefore growing old with multiple comorbidities, which is a totally different challenge for healthcare and how we provide it. So multiple comorbidities with lots of clinical conditions. So patients growing old with with diabetes, with lung conditions, with reduced mobility, obviously the effects on cognition of growing old, and that's a new challenge, a different challenge to the challenge that we were looking at when say the National Health Service was created over 70 years ago, and I'll say a little bit more about that in a moment. So it's, in a way, it's a bit like the pensions challenge. It's a bit like how do we address this issue of our young population being able to provide for our elderly population, and pensions is one aspect of that, but obviously the provision of healthcare for an aging population is another. So perhaps the money is the major challenge. Or maybe it's just the way that we're doing things. Maybe it's structural. Maybe the whole concept of the National Health Service is flawed. Maybe there are aspects of it which we really value. Maybe there are aspects of it which we want to preserve, and maybe there are parts of it which are unsustainable, with the number and the variety of treatments, the expense of treatments which are available. Perhaps again, that means that we're unable to provide that in the way that we foresaw over previous decades, and we've, in a sense, been, you might argue, in a slightly uncoordinated way, investing in private healthcare outside of the National Health Service, and so I think there's a clear question about how we manage to in a coordinated fashion get the best out of our investment into healthcare, and that's our investment as taxpayers into the National Health Service, and our investment as buyers of health insurance or self-payers into the private healthcare service, which runs in parallel and with overlap with the National Health Service. But maybe that would all be okay if we were getting it right operationally. Maybe it's an operational challenge. Maybe we're not managing things well enough. Maybe we look at the challenges in the wrong way. So we have a smaller inpatient bed capacity than a lot of comparable nations, and that leaves us with issues of occupancy in those beds, which, when the beds get full, lead to issues with being able to admit patients, whether that's for elective work or whether it's long waits in the emergency department for people who need to be admitted to hospital beds. And there are clearly elements of digitalization which can help us to try and address that, knowing what information we've got at a particular time about, for instance, live bed states, so knowing exactly where patients are in the pathway, what's going to happen tomorrow, where we're going to have beds available, and so on. So there are operational challenges as well. The final challenge that I wanted to mention was about the health of the population, and of course, there's that old saw about the National Health Service, is that it's neither national, it's not about health, it's about disease, and sometimes it's not much of a service. And I don't want to dwell too much on that, but the element around it is about keeping people well, so keeping people in good health. And how do we best do that? How do we address the issues of the causes of ill health, whether it's about prevention policy with smoking, alcohol addiction, whether it's about how do we address issues with obesity, keeping people well and adding value to the service that we deliver. So thinking about how many healthy life years expectancy we give to the population that we serve. So those are some of the challenges. I didn't want to stand here and try to give an overview of how we're going to fix things, how we're going to fix healthcare. I think that's more about the discussion and the conversations we're going to have. And of course, there's many other things that you could point to. You might point to the pharmaceutical industry, and you might say, well, look, that's where that's where we need to make changes in the way that that works in order to provide care. You might point to research. You might point to research as the savior if we can incorporate research into all that we do. You might point to the very slow glacial rate of change that comes from research. When we know that something is beneficial in healthcare, healthcare is very slow at adapting and adopting change. And you might point to a number of other issues. And so, as I say, my point really isn't to say what are the challenges facing healthcare. I've given you a summary of some of the ones which I think exist. But what I do want to do is to have the conversation today about how we make changes and interventions into the way that healthcare is provided, and to think about why those interventions may succeed and why they may fail. Because you can take your choice from that list of challenges facing us, and you can come up with another one as long as my arm of other challenges. But any of us with some responsibility for affecting how healthcare is delivered have a responsibility and a wish to try and make sure that whatever we do succeeds. So I've put it to you today, and about 4 things which need to be in place for interventions to succeed. And I think the first is a clear definition of the problem, to identify the problem that you want to fix, and to get a good, clear definition of what that problem is. And that problem may be we don't have enough beds in hospitals. The problem may be too many people in the population are smoking. The problem may be that patients find it too difficult to access their GPs for consultations. So you need to identify that problem. The second thing that we have to align is the narrative around that problem. So how we articulate it, how we make clear that that is a problem that's been identified. Having that conversation with multiple, what we've come nowadays to become used to terming stakeholders, so multiple organisations, professional groups, cohorts of society, different populations. How do we have that narrative around this is the problem that we've identified? We've identified the problem that we are unable to provide care at this level. How do we have that conversation? And that depends on clearly articulating the cause of the problem. So I'll talk about a couple of examples in a moment. And if the cause of the problem doesn't resonate with people, then it's going to be very difficult to make the change stick. Thirdly, and important, I'm sure, around what John was talking about with cybernetics, is the role of data. So we have to be able to clearly show that the data supports our proposal for change, so that we've got the data to show that we need change in that area, and that we can continue to back that up as we make changes to show that that we've got progress. Often the data is disputed. We all like sitting in meetings, looking at data, poring over it, saying, is it this, is it that? Oh, but have you shown that? And you didn't cut it this way, and so on. So often disputed, and then of course it changes as well. So so we need to keep at all times the intervention aligned with the data. And then finally, the intervention itself. So actually deciding what it is that we're going to do, having identified the problem, having created and built a narrative around that problem that we can use to get different stakeholders on board, having demonstrated that the data shows that this is indeed a problem and that investing in sorting it out is going to be worthwhile. It's then around what the actual intervention that we're going to make is. And I put it to you today that that those 4 things have to align in order for the intervention to succeed. So we have to go from the problem to the intervention in that way, and if they don't align, then the intervention fails. or if not fails, then doesn't succeed entirely. And I'll just finish with a couple of examples of interventions which I've, to varying degrees, seen or overseen in healthcare, and to what degree we succeeded. So when I was clinical director in the radiology division at UCLH a number of years ago, we had a big problem with a backlog of uncompleted work. So of patients having scans to investigate one thing and another, and we had an issue with a number of those scans which hadn't yet been reported and interpreted by a radiologist. Now, so that was the problem, was that scans which were not getting reported. The narrative around that is tricky. So the data is quite clear. You can look at how many scans you performed, how many have been reported, and what the gap is. But the narrative is tricky, because if you're talking to a group of interested radiologists, you may well get the answer that the issue is that we don't have enough radiologists, we haven't trained enough radiologists, we haven't recruited enough. So that's where we are. If you're talking to somebody managing the system, you might get the answer that, well, it's because of competing interests and pulls on time. So it's that we've set up a system now where we have a number of meetings, multidisciplinary meetings, coming together to discuss patient cases, that takes up a lot of the radiologist's time, which previously didn't, and that's what causes the issue. So whatever policy whatever intervention you then make to try and address that, you need to keep that aligned. And the intervention that we took was to set up another group of radiologists, and to be able to use that group of radiologists to in a measured way to do extra work to report the backlog of unreported imaging. And that was tricky, and it succeeded to a degree. But I think that the place that we had the issue there was between the data and the narrative. So building the narrative for different groups was difficult in trying to bring in the change that we wanted. So secondly, is about, I'll come back to this, the issue again about bed capacity and about how many beds we've got for to admit patients to hospital. And if you haven't got enough, it's difficult to admit patients. As I say, you then get a long wait in the emergency department of patients waiting to be admitted to the hospital, or you get a long wait on your elective waiting list of patients waiting to come in for hip replacements or shoulder things, or other elective things that you're bringing people into hospital for. And so the narrative then has to appeal to the different teams who each have the interests of their patients in mind, and that can be difficult. And the data was uncertain. The data can be uncertain. The total number of beds, the total number of beds that are open, the total number of admissions can be unclear, and so making the policy intervention is then difficult because of the uncertainties around the data. And we introduced a digitalized way of looking at the bed capacity and the patient flow. We moved from a service where we were very much reliant on bits of paper scribbled on, numbers of beds and what's happening to who, and on people walking through the hospital, looking at where and identifying where the beds were. And we moved that into a more modern digitalized system with electronic capture of that data, and use that as a way to try and drive efficiencies in patient flow pathways, in the admission process, in the discharge process. Again, we've succeeded to a degree with that. There's elements where it's been very difficult around different well-established practices in different areas and in different groups. So using what I've been doing is using these 4 areas to align to think about how we can make these things stick. So I'm going to finish there. The challenge that I leave and that we will come on to talk about when we're talking in our groups is then about how do we make sure that that policy changes or interventions that we make in healthcare, how do we make sure that they stick and that they work and that they improve things for us? Thank you, John.
Thanks, we're not going to take questions at this point because we've got lots of things to talk about. We're going straight on to, well, I get it right. I think it's the first time I've ever said this, Professor Chris Murray. Chris is visiting professor at Strathclyde in something to do with urban environments. I'm not entirely sure what. He and I, again, have worked together for a number of years, particularly around Fusion 21. And Chris is going to talk to us about transforming cities. So, Chris, thank you.
Thank you. Thanks, John. And thanks for inviting me. Very pleased to be here to speak to you all. And as John, I don't know, turn anything on or off there. As John sort of intimated, you know, my background has really been working with cities, mainly here in the UK, but internationally as well, for the last sort of 25, 30 years, including most recently a network called the Core Cities Group, UK Core Cities, 11 big cities outside of London, and on the process of things like devolution, creation of combined authorities, metro mayors, and the legislation behind that. So I want to talk to you about why I think cities are so important globally, but also here in the UK, and how cybernetics might be able to help with some of the challenges that they face. So first of all, when I say cities, immediately when you present on cities, people say, what about towns? What about villages? And of course, those places are absolutely critical too. And when I say city, I really mean any kind of large urban settlement. And all those other places cannot be forgotten. And if you think about a city region, somewhere like West Midlands, Greater Manchester, actually they've got all of those types of settlement within the city region. They're all part of the offer. And I'm just very keen to underline that point because my view is it's very important to avoid the divisive kind of arguments and narrative which has come out fairly recently again in national politics that pits places against each other, particularly in the UK. It's a very small country. You know, everywhere is interlinked. Nowhere is an economic or a population island in somewhere like the UK. But cities are critically important to all of that. Cities need towns. If you're a town near a poorly performing city, you need your city to do better. And if we don't get things right in cities, the sheer scale of them means that we're not going to get it right anywhere, that we will fail. This is absolutely critical because cities are now the primary human habitat. In 2008, for the first time in world history, 50% of the population lived in a city. In about 50 years' time, that's going to be near 70%. And just to give you an example of how rapid that urbanisation has been, if you go back to 1900, it was 16% of the planet lived in a city. And in 1800, it was only about 6% of the planet lived in a city. So this represents an absolutely massive shift in the way that we live. And it points towards us becoming a kind of homo urbanis, if you like, a sort of people of the city. And the policy and the systems to deploy it and the governance that we have, the structures, are struggling to keep up with that shift. But if we, I mean, the UK is highly urban already. It's about 80% urban. It'll rise a bit here, I think, but not a great deal. But to give you an example of the relevance of those settlements to the future of the UK, they take up about 9% of the land mass, big towns and cities. They deliver 70% of the economy, and they create 60% of jobs in the UK. So just something to think about. So I think I'd argue that now the future of our species is closely connected to the future of our cities, at least in the next stage of human evolution. But if we look at these figures in a different way, if we turn them on their head they tell a slightly different story. Modern humans have been around for about 200,000 years, depending on which bit of science you choose to accept. But you know, certainly around at least that kind of period of time. Cities, at the most 9,000, maybe at a stretch 10,000 years. And as you can see from those figures, that demonstrates that for all of that period, hardly anyone in terms of global population historically has lived in a city. You know, cities are very recent in evolutionary terms. We're very adaptable, but they really challenge us, and they challenge our psychology as much as anything, our mental apparatus. I did some research on this, published a book a few years ago called Psychology in the City, available at reputable online book depositories, and probably some unreputable ones as well. But in that, we looked at the fact that mental health, thinking about health, is twice as bad on some measures in urban than non-urban areas. Stress levels, depression, anxiety, prescribing rates, loneliness, paradoxically, all worse in big urban areas. So there's something going on there. Now, a lot of that is linked to deprivation, but I think there's more at play there. And this is not to, and none of this is to say cities are the problem. You know, they're not. In my view, they are the solution. They can confer a kind of psychological robustness on people that live in them. They ask us to live alongside and experience and deal with difference. So they tend to be more tolerant places. They are potentially the most sustainable way that we could live because of their density, and they are capable of cohering multiple identities as Liverpudlian, New Yorker, Glaswegian, you know, whatever, in a way that nations, frankly, are struggling to do at the moment. But we didn't start in cities. You know, our mental apparatus did not evolve there, and we've brought parts of our anciently formed past into cities, and those needs must be satisfied or we don't function well. And some of the best ones, the best known, are, you know, things like greenery and water and so on, but there are others as well. Just the whole kind of fabric of the urban experience and the way that that mitigates for or against our well-being, and the evidence of this on this is really, really strong now. And you know, in one sense, we've got perhaps still the mind of a village living in the body of a city. All of that's really important because I'm going to go on to talk about systems and economy and infrastructure, but I just didn't want to forget that point, that the city is the people. And there's this lovely phrase from Patrick Geddes, who used to write about cities, that cities are a drama in time as well as a space in place, which is just about how we interact and live in them. So COVID was predicted to change cities, but the flight to the country didn't really happen. For a few that could afford it, generally older people, it did. There were probably people who were going to do that at some point anyway. Most people who live in cities couldn't leave. They couldn't possibly afford to leave the city, and where would they go? You know, what would a village with 50 million people, which is the urban population of Britain living in it, look like? It would look like a city. So you're just moving the deck chairs around, frankly. Footfall is returning to most large cities in the UK, but the thing that has changed is our relationship to urban living and urban working. You know, home working, the way we move around, public transport use, online retail, reasons for visiting city centres, the way that we want and need to access amenities. If you were stuck in a 2-bed flat with no balcony in the centre of Manchester during lockdown, you're going to think very differently about access to amenities, green space, the quality of them, and so on. And the idea of the 15-minute neighbourhood kind of coming round again, an old idea actually. I worry about that slightly, I have to say, because I think that will and does work very well in affluent areas. I wonder what that would look like in a much less affluent place. So I have concerns about that. So, and cities have got other really critical challenges here in the UK and globally. You know, climate change is a battle that in large part is going to be won or lost in cities. It's where emissions are created. It's where consumption is generated. Deprivation is generally a lot higher, more concentrated and more persistent in cities than non-urban areas. Poor population health is correlated to that. And that's also linked to productivity. And as you know, we've got a big problem with productivity in the UK, particularly in the big cities outside London. You know, if you look at most of the developed nations around the world, Europe, America, and so on, you would expect the top 10 or so, let's say, 6 to 10 big cities to all be outperforming the national economic average. But here in the UK, only London and Bristol do. No other city in the UK outperforms the national economic average, and that is really odd. That's linked to deindustrialization, but deprivation is a major factor in low productivity. We did some analysis of this with the core cities, and about 40% of low productivity on average across those cities is linked to deprivation. So that's people, distant from the labour market, in poor health, no skills, or very low levels of skills, and so on. And that equates to about £24 billion a year that we're missing out on in the economy because those people are not able to access or contribute to the labour market. The total productivity gap between our big cities and the national average. So if all the core cities were performing at the same level as equivalent cities in the EU or US, is about 100 billion a year. So that's like adding the motor vehicle industry almost to the UK economy again. So it's really significant. Deprivation is a massive factor in that. I worked on a study with the OECD, came over to the UK to look at this specific issue, and they highlighted a lack of local control over finances, legislation and policy, and a centralisation, high degree of centralisation of the UK state as major factors in this productivity conundrum, plus long-term underinvestment in cities, particularly outside the capital, not to open up that north-south debate, because I think it's more complex than that. But UK cities, just to give you an example of this, control about, including London, about 9% of the total taxes raised in that city. So that is council tax and a bit of business rates, not all of business rates. The OECD average, controlled locally or regionally, is 25% of the tax base. In Germany, it's 35%. In the US, it's 50%. And in Tokyo, it's a whopping 80%. But Tokyo, frankly, is the size of some nations, and I'm not advocating that we should go down that route. But we do need more local control, and we're way behind on that, way behind. So the response to that over the last 20 years has initially been to look at the regional architecture of the UK, regional development agencies and so on. But that was still a fairly top-down way of trying to solve things. It was more about Whitehall being in the regions and the regions kind of being in Whitehall, if you like. And then after abolishing the RDAs, we moved toward devolution, a drive toward devolution over the last decade or so. City deals, formation of combined authorities, metro mayors, all designed in part to deal with some of these issues, but unfortunately went hand in hand with austerity. So there was a very difficult balance to be struck there, and some difficult deals were done. In my view, that was never really proper devolution. It's essentially the decentralisation of some functions and some of the powers and some of the budgets to go with that. It's not fiscal devolution, as you would see it in most other developed nations where you've got those additional local controls. So it's had a limited impact on the way we're able to respond to these challenges. So in response to that, the drive toward place-based policy has increased as a further response to those limitations. and also indeed to austerity, because one thing that austerity did do is accelerate the need for greater local collaboration and pairing up with other organisations and their budgets. So place-based policy is centred around attempts to pool budgets, to co-commission public services, to align activity local and nationally within a defined geography, city, region, county. But it's really difficult to do because the benefits are generally very long term and the budgeting is very short term. So if you think about, you're really interested in what you're saying about the health system. If you think about health social care, for example, a lot of the influence in terms of change is with the local authority in spending on social care, but they have very, very limited ability to do that at the moment, very low spending power generally. If that's done in the right way, the argument is it would then benefit the NHS, and the NHS would save money. So should the argument be that the NHS invests into social care in order to save that money? But that's very long term, and the hospital will quite rightly turn around and say, okay, if that ward doesn't empty, who's going to pay for that? So you've got all these conundrums, playing out in place-based policy, and it's the same across the piece with other public services. All of that, I think, is a recognition that solutions can't be delivered at a national level alone, that the sort of issues that we're dealing with, this 21st century complexity, requires local responses, and you need the tools to be able to do that. You can't do it top down. So where might that link to cybernetics? Well, inspired in part by John Beckford's intelligent organisation, Intelligent Nation, we had a conversation about whether there's something at a level between those two things that we might describe as the intelligent city that we could work on, where we could think about how cybernetics plays into the systems and the complexity of the city to help it function better. And it's a kind of complexity par excellence, really. It's one of the most complex, perhaps the most complex thing we've ever created. And you've got multiple agency and actor controls and governance, pulling in different directions, often unintentionally undermining itself, despite some very good attempts to do otherwise. And cybernetics and systems thinking has not been widely applied to those domains, to the city and to its governance, with, of course, exceptions. And cities are now the scene of constant change. So we've had these sort of debates about, we're moving from model 1.0 to 2.0 to 3.0 and so on. I don't think we're doing that anymore. I think that's an old argument. We're just in the middle of constant flux and constant change. And you've got to deal with that, and you've got to deal with that uncertainty when you're in charge of the city. That's not just the council, actually. It's, it's an argument for cross-sector governance here. But our systems are still stuck in that dynamic, that way of thinking of, well, what's the latest challenge? And let's turn the oil tanker around to face toward that challenge. And by the time you've done that, and frankly, most governance changes at a very glacial speed, then the next challenges come up and your governance isn't fit for purpose for that. So the question becomes, is it possible to create a model of governance for cities that's designed and constructed in a manner that is flexible and adaptive from the outset, that's got that feedback loop that John was talking about built into it, so it can constantly adapt in an inclusive way across sectors, across the actors, that can make these things work in cities. Currently, this idea is no more than what I've just said to you in an article that myself, John, Chris and some others have written, which is on John's website, and we're just inviting people to get involved in the debate on that and share some ideas, respond, critique, and see if we can move it forward. If anyone joining online has got research grants available, we're very happy to speak to you, of course. And I think actually, seriously, it would make a fantastic and really interesting research project. And I know lots of cities who would be really, really up for that. Because the governance stuff might sound a bit dry and a bit techie, and people start yawning when you talk about governance. But you all know it really is. It's something we've got to get right. And if we don't get that right here, the competition will. And we are in a global race to some extent here. Cities collaborate internationally, but there's an element of competition. There's an element of competition within country. So it's, a final point is that this is absolutely vital for national prosperity, but also for the most vulnerable people in our communities, for the sustainability of public services, for the environment, for those really challenging issues around social cohesion and so on. We need to get that right. And I think cybernetics could make a fantastic contribution. So I hope that stimulated a bit of thinking. I'm interested to hear what you've got to say. And do come and join us on that journey toward the intelligent city.
Thanks, Chris. Right. So I do gather that you mainly had a good morning. It certainly seems like it from here. Building on this morning is the aim rather than starting again from scratch. I'm delighted to introduce to you Duncan Cole, or Dr. Duncan Cole, I should say, shouldn't I? Duncan stumbled across me and us at a systems event about 18 months ago and has been unable to escape the clutches ever since. But he and I and Chris have been working together a little bit over the last 12 months or so, thinking about helping Duncan to take a very specialised healthcare service to across the whole of Wales without having to replicate everything 73,000 times. And Duncan's going to talk to us a little bit about that, and when he's bored and fed up, he'll stop. So, Duncan.
Okay, thank you. Thank you very much, John. Thanks for the invite to speak. I'm just going to see.
You have to roll it rather than click it.
1 second, I'm not quite sure I've got this.
Technical help. I wouldn't use that one. I'd use this one up here.
Yeah,
So if we get
there, right,
up there and then click on there, is it? Just roll it and it should work.
Okay, I've got to put it on slideshow. Thank you.
Yay.
Okay,
Well done, Chris.
fantastic. Thank you. So thank you. So I've got about 20 minutes or so, I think, just to give you a bit of an overview of the problem that we face, which we've sort of encapsulated by this sort of issue of managing distributed health services. So a bit about me. So I'm a consultant in Cardiff. I'm a clinical academic on the teaching side, and I'm currently, with my other hat on, director of the medical programme in Cardiff for undergraduates. With my clinical hat on, I am a consultant in inherited metabolic diseases. So these are very rare, unusual diseases. I'll talk a little bit more about them as we go on in future slides. But suffice to say, these are very rare, unusual conditions, and with limited expertise across the UK. So just to talk about purpose, we have actually done a little bit of work around this, actually simulated by by workshops that John and Chris have helped us with. You can't see it very well behind there, but we actually have developed a logo which sort of helps to give us an identity on our correspondence with it. Do I need that out of the way? There we go. What I did there. So a little bit of a logo, and to explain what that is. So Cardiff is known for a very rare condition called porphyria, which some of you may have come across in The Madness of King George. He didn't have porphyria, but that's what the thinking was around at the time, I think, or subsequently. And that's what that this is here. That's a porphyrin ring, and this is DNA in the middle because we deal with inherited conditions. So we've done a little bit of work around what we are, what we do, and what we're aiming for. So this is the purpose bit, I guess. So we've heard quite a lot about purpose. So we tried to define that for ourselves. Whether this is right or wrong, I don't know, but we had a go. I'm never entirely sure of the difference between vision and mission either, so I'm sure I'll be corrected if I get this wrong. So what are we trying to do? So we have a group of patients, so we shorten inherited metabolic disease to IMD. So our vision is for all of those patients with these conditions in Wales to be able to access care, which is of high quality, wherever their home is. Okay, whether or not they're currently known to our services, so specialist inherited metabolic disease services. And what we're doing day to day to be able to try and achieve that, or what we want to be able to be doing, is deliver excellent care to those patients effectively and in an efficient and sustainable manner, and also be a great place to work whilst we're doing this. So there are some challenges in that, in terms of looking at what is effective. So trying to define what that means for each of these, for each of the conditions we deal with. And efficient and sustainable was a little bit of a rocky thing at the moment, and that will come on to some of those issues. Part of that's around workforce, and to be a great place to work while doing it. We've recently had some problems with that in terms of the communications, and so part of the problems that I'd like to sort of your sort of thoughts on, and for us to sort of take forward on one again. Okay, so just a little bit about our service. So this is Wales, of course. What you've got on the diagram here on the map is various health boards within Wales. So just to orientate you, so Wales, of course, has a different health system to England, to Scotland, to Northern Ireland. Okay, we deal with such a specialised area of medicine that all of our patients come from all over Wales. But we also need to use services in England for super specialised conditions, so where we haven't got the expertise either, and there's only one centre or two centres across the whole of the UK that might be managing these conditions. Now we have a variety of clinical streams of practice that we sort of mentally group patients in, and that sort of reflects the structure for the various clinics and services we run. So of course we've got new patients coming in. Sometimes, so I run an adult service for adults, so we've got a paediatric service aligned with this, and patients coming in to the adult services are usually often transitioning from paediatrics, and for those and for patients when in terms of diagnostics, the new presenters where this is coming up as a possibility to explain their problems. With paediatrics, we're also getting patients in through newborn screening as well. We've got another stream where we've got patients who can what we call decompensate, so and go a metabolic decompensation periodically when they become unwell. So those patients need a facility to be able to bring them into hospital quickly to manage them. And our challenges with that is that for some of these patients, the treatment is very specialised, and the diagnosis is often not known to the people seeing them. So you've got a problem with needing to provide local care in a local hospital with quite specialised input, which doesn't exist locally. We've got a group of patients, probably our largest patient group is something called phenylketonuria, which is on the newborn screening programme. This is a disease where if it goes untreated, patients can become mentally disabled fairly quickly, have significant learning disability and require lifelong care. So it's a neurodegenerative type of problem, essentially, due to very high levels of phenylalanine, and amino acid, a component protein in the blood and brain. So with treatment, we can normalise that entirely. We've got people that have gone on to university degrees. You would never know they've got this unless you ask them what they eat, because it's a very, very specialised diet. So we have a clinic focused on that because it's a large group of patients. We've got a sort of proportion of patients who haven't got that, but have also got things that don't decompensate. So phenylketonuria does not decompensate to cause an acute problem. We've got a number of other conditions like that that also require very specialised dietetic input. We then got some of the more complex diseases, which are these two down here, which are multisystemic in general. There's a variety of different issues that they may have, varying depending on the disease, and they usually require a very broad multidisciplinary team of different organ specialists as well as ourselves, local care, in order to treat. We've got lots of professional groups. Okay, so again, sort of a little bit more of the context. Our professional groups include, of course, medics such as myself, specialist nurses, dietitians, pharmacists, physiotherapists, clinical biochemists. So these are the people in the laboratory doing a lot of the analysis work and interpretation for us, and very highly specialised investigations, and clinical psychologists. And then we've also got a group of admin and administrative staff as well, which is quite a new thing for us, actually having a team. Usually was previously dependent on one or two people. We've got network managers, data coordinators, a recent addition of a PA and business support officer, and we've got a team of service coordinators. So that's broadly who's involved in the team. That's about 30 odd people across paediatrics and adults, and not all of whom are actually full-time doing this job either. And we've also got, of course, a lot of non-specialists involved in patient care. So all these patients need primary care, they get common diseases as well. They need local secondary care teams if they go into hospital, particularly emergency medicine teams. So there might be organ specialists in a local hospital, might be emergency medicine for acute problems. And of course, there may be some community teams involved as well at various stages. Perhaps visiting them at home, or learning disabilities teams that are managing things, in a coordinated way for patients with more sort of complex needs. The other problem we face, apart from having a huge range of diseases and a large team of with lots of different people, is the geographical spread for where our teams are based. Previously, we've all been in University Hospital Wales in Cardiff, and we just managed things from there with outreach. But now we have we still have the South Wales team for adults. That's in the main hospital. We have our laboratories there as well. But our paediatric team now has a small group of specialist staff in Cardiff, but the medical team are based in Birmingham. So we've got an issue across boundaries there. We've recently appointed to a couple of posts in North Wales, where we have a consultant and a dietitian now and a nurse to follow, and that's up in Wrexham and Isla Hospital. And the paediatrics, however, is run through Liverpool as an outreach service. So you've got quite a wide range of people in lots of different locations trying to deliver this care across paediatrics and adults, and then trying to transition patients from paediatrics to adults as well. The other problem is, even on site, all of our professional groups are based right across the hospital. We're not co-localized either. So I think I calculated that there's out of the 30 odd people here, we've got something like 15 to 20 different locations people are actually based in. So communication between the team is challenging. So now the challenge is, how do we then effectively manage this? Okay, it's distributed health services for patients with these types of diseases. So we're thinking about actually more, I guess, a more specific case, building on what we we're talking about earlier. So how do we actually change from the sort of small service in South Wales to a much larger service across all of Wales with multiple different teams involved? We talked a bit about previously in previous workshops, including this meeting, about how we think about patient flow as part of this. But what I'd like us to have a think about now is actually how we as a health service team manage this, and manage the complexity that's involved, whilst making sure that we still deliver that high quality care. And we've got some problems that we're facing, and I've alluded to some of these. So we've got communication with the patients, for example. They're all over the place. There's lots of different routes into the service, lots of different teams involved. How do we improve that so the patients get their queries to the right person at the right time? Within the healthcare team itself, we're all over the place. Lots of people relying on emails, lots of people getting the wrong end of the stick, receiving emails or letting their frustrations come out. How do we avoid that? And how do we avoid the communications across these big boundaries as well? Because we have all sorts of problems, IT issues across boundaries, the sharing of data and so on across boundaries. We've got a problem with clinical expertise, which is limited. So, for example, I've been the sole consultant in our service probably for the past 4 years or so. So, if I go off sick, that's a problem. We've got a plan to implement to improve that, but it takes time. When other members of our team are off sick for whatever reason, or have to take prolonged leave, we're left with a major hole in the service. How do we get the resilience to be able to avoid that? What sort of approaches have we used? So we've started to think very much about this and looking at trying and work on a more regional basis and getting support from outside of Wales to be able to reinforce some of this. But is this the best way to do it? Are there any other things we need to think about? I think I've heard murmurs of accessing clinical information across boundaries. That is very much a big issue for us at the moment. It's actually stopped certain members of the team working in any sort of effective capacity for about 6 months, because we can't get the right information in front of them in order to see the patient and manage them effectively. Big issue for us, so it's very localized in particular areas. And how do we manage that growth of the service? So as I said, we're going from a small unit where there was quite a lot of workarounds and in terms of how we ran things, but it worked. We're now trying to transition ourselves to a national service that's a little bit more, hopefully, robust, but we need to maintain what we're doing in the present. Comes back to that trial look by Pete's again, trying to manage what we're doing at the moment whilst actually implementing our vision for the future. But there's that process of moving from one to the other, which is problematic, because when you uncover things that were previously done and found that actually they were workarounds and actually weren't actually the right way to do it, there's a massive great delay in the system to try and get things back where they are, and that actually impacts then on patient care, on appointments and so on, simply because we're trying to transition and the system is too slow to respond to us. So nothing we can do about that, but how do we manage that? So we're having to do workarounds to address workarounds in order to get to a position where we've got a more sustainable solution, but we're not there yet. So how do we manage that effectively? And that's causing lots of disgruntlement and difficulties within the team. So trying to keep the team on task as well is challenging under those conditions. So I've had just a couple of thoughts here in terms of questions. So I've thought a bit about the VSM, the systems on. Can we use that? Are there lessons we can take from that in terms of how we structure things? Do we, for example, so we made a decision to base things on care needs of patients with particular types of disease, so we know what each patient group needs, and we structured our teams around that. But we've got geographically distinct units in North and South Wales. So should we be organising things on a regional basis in Wales, or should we be organising them on a patient-oriented or condition-focused basis? Does the VSM help us with that and enabling that care to then be effectively delivered? And what about the information and communication in this system? How do we deal with the problem with that information hitting a barrier across across the team, such that we can't be actually stopping us do our jobs properly, and therefore shifting the burden onto other members or other parts of the service to pick up the pieces of that, where we don't necessarily have capacity and causing stress on the system. I don't think there's necessarily an easy answer to that. We've tried to use systems across organisational boundaries, but we're still hitting a problem with the actual clinical information or local systems being available, either because it's incomplete, or we literally cannot access it because of the permissions problems, without huge delay and difficulty in the system. So those are the issues, those are the problems. I'm hoping that you'll be able to help us think about some of those things. So just to summarize them, what I'd really like is some help with how do we manage this problem, particularly how do we manage information and communication across these systems, not only within the team, but across Wales, across distributed teams in lots of different locations. And how do we, in the sort of mantra of a lot of the things we do in the NHS, how do we deliver that care well to patients wherever they are, the local way? Because some of them will travel, but some of them won't travel long distances. So how do we deal with that within the limited capacity we have? I hope that was clear. I will circulate around during the discussion to answer any questions.
You can probably take 5 minutes of
I can take it. Yeah, that's fine. Yeah,
because splitting you four groups is quite hard. Without commenting on what Duncan said, if you've got questions for clarification.
Yeah.
How many people are on patients in real?
We've got about 500 patients at the moment, and that's mainly the adult service. We've probably got about 400 actually adults now, pushing on to 500 depending on which bits we use. And so that's the adult service, and then we've got another 200 pediatric patients, children.
So we're all coming. I mean,
Yes.
Yes.
Absolutely. So the paediatricians get really good at what they do. And so we see more and more survival and, with better and better treatments. And so we're getting quite a lot through from pediatrics now. So the increase is inexorable year on year. Yeah.
Jane, Tracy and Daniel, I think, in the next order.
Okay.
But you can correct me if I'm wrong.
Yeah.
Just to build on that question. In my lifetime, the assumption would have been that a child with one of these diseases would have died. So medicine has moved on such a long way that we now have an ever increasing population that's labeled.
Yeah.
That's why it's growing.
Yeah. I mean, some clearly, still do die from these diseases at young age and various other ages. But the survival is getting better. There's better awareness of these diseases as well, both in children and in adults. So we're learning about this sort of, what we call attenuated milder forms of disease as well. So that's becoming more of a thing as the population of adult physicians, such as myself, grows, word gets out and people start to realise. So we've got growth in a number of different areas, and we're screening for more diseases as well now. And so we're picking up more children at an early stage.
Do you have a genetics?
Yes, we do.
Daniel.
Thank you. Duncan, you've articulated the huge big macro problem very clearly. It's made up of micro problems. What is the one micro problem you can solve that would make a big difference?
What's the one micro problem?
Cloning.
Yeah, our problem at the moment is very limited medical expertise, I think. Yeah, so we have had an open consultant post for about 2 years. And we've had to essentially grow our own. So I've got 2 trainees coming out, hopefully in the middle of next year, who will be able to hopefully solve that problem partially. We've also appointed to a North Wales post, which we didn't have previously. So I think the medical expertise is a very limiting factor. But if the other thing I would try and solve at the moment is actually the team working as well within our team, because I think that's causing problems and delays. So that between the teams actually working towards the same goal at the moment is not working particularly well. Lots of cross purposes.
Tracy.
Is the MDS service, is that bed-based in some areas, or are you going around to hospitals?
Yeah, so it's mainly outpatients. So we have no inpatient beds as a service at all. So when patients come in, they're always under another physician, even if they're in the same hospital as me, or my colleague in North Wales. So a lot of our work is done over the telephone in supporting other people rather than direct care. We would like to do more outreach, but we simply haven't got the capacity in terms of the amount of time we're spending at the moment. That's right, yeah. So an organisation that sits above the health boards called the Welsh Health Specialised Services Committee. They commission nationally specialised services, most of which are delivered through the Cardiff Centre, simply because that's where all the super specialists are. But they also commission some English centres as well. So we have had a total of 3 business cases accepted by them since 2007 when the service started. So we're quite young, and we're reasonably rapidly growing. So we started off with about 160 odd patients, and we've got almost 500. And that's over a period of sort of 10 to 15 years that growth has happened. So every time we get a new business case approved, we're sort of already behind the curve. So that's part of our challenge. So yes, it's nationally commissioned.
Firstly, do you have some kind of geographical map of demand?
We're in the process of doing that, actually. Yeah. So sorry?
A lot of mountains.
There are a lot of mountains, absolutely, and where the patients are, we're sort of trying to put onto that map so that we can map the services we need a little bit more accurately. We know there's a big concentration in South East Wales, which is fortunate because that's where we are. But we also know we've got little clusters, and they're in West Wales, we've got quite a lot of people, and in Anglesey, we've got quite a lot of people as well. So it's only just becoming apparent where those clusters are, but So it's a very valid point.
And pursuant to that, but not related, what is the largest like cost that affects whether you provision that you are not responsible for it?
The largest cost that affects our provision. That's a very good question. I can tell you what our biggest cost is, and that because we deal with some very high cost treatments, which goes straight back to our commissioners. And so for some of our patients with the lysosomal storage diseases, we're talking £100,000 per patient per year. Most expensive patients about £500,000 per year. So I was the most expensive consultant in Wales at one point. I'm not anymore because you've got things that cost well over that. In terms of other things that I'm not responsible for in terms of costs, services is a little bit more difficult to answer, I guess. We are quite limited by support from other services. So other specialists getting involved is potentially a big cost. As I said, a lot of these patients need lots of other different people involved in their care. We're only funded to provide very specialized services, but they still need an awful lot of other support, many of them, and I'm not responsible. It's a question, so you have to find people willing to take on patients locally. I'd really like to have linked clinicians in every hospital, to be able to manage things, improve expertise, but we've only got that for a couple of hospitals, probably in Wales, who are willing to take that on. But that is a big problem as well. So I would say probably that actually is all the other care that these patients need, that we as a team try and coordinate. So
David and then Margaret.
Right, two questions. We tend to think
Last two, by the way.
cybernetics as being about the links between nodes and finding optimal linkages. Presumably your nodes are individual people and groups of people doing jobs, and your links may be all sorts of things. But how far is your problem? Do you see it as being about links between the nodes? And how far is it just about upgrading the nodes? The people, like each cell in my body, allegedly has the plan for the whole caboodle, and it can sort of tune into that appropriately. The more intelligent you make the nodes, the less intelligent, in a sense, fine-tuned you need to make the links so that you're complex. So there's that dilemma. The second dilemma is, speaking as someone who was the head of a special school for children with severe multiple and profound learning difficulties in Islington, we tended to deal with the successes of Great Ormond Street. And if you have a few drinks with a doctor, sometimes they will say, I saved their life, but given the quality of it, maybe I shouldn't have. And I've heard parents of such children say such things. How far dare you put that into your equation?
Yeah, I'll deal with the first one. So the quality of the node, which individual practitioner, I guess, within the service, if you count it as that, varies from within our own service, can vary, because of course, when we have an experienced person leave, we then got the inexperienced node. So it's that sort of upskilling and training and development then becomes our absolute focus. So we are developing ways of doing that more effectively when we do get those changes in staff. Within our own service, I think it's the links that are the problem at the moment, because I think actually we've got some really good, really experienced members of staff at the moment. Our challenge is getting all of that to work effectively across all these other boundaries that we're trying to use. So it's the linkages that are impairing us at the moment. When it comes to interacting with those outside of our service and the wider healthcare team, we are definitely dealing with both of those things, because of the knowledge levels, the skill levels of the individuals that may be seeing these patients elsewhere and the other healthcare teams that are involved, but also the communication with them. We try and communicate as well as we can. Sometimes that's one way. We never get anything back in the other direction, for example. it works best when we talk to each other, unsurprisingly. But there's when you've got several hundred patients, all with many of which have got complex needs, that becomes a little bit limited. Our capacity to do that is limited. So there's a lot more left to other sort of modes of communication, which may or may not be effective. So I think it depends, I guess, from which perspective you look at it. They're definitely dealing with sort of a mixture.
There's a problem at your staff if you can't solve it.
It's throwing the problem at you yourself. Margaret.
I have a question about control. What if you have to single out one thing you have to control and one thing you have to control of?
Yeah.
What would those two separate primary desires be?
Okay. So in terms of what we the best, sorry, can you repeat that? So there are two things. I just yeah.
And what you control for in order to achieve your purpose, which is to deliver this special cancer to
Yeah. Okay. I think I'd like to have control over over appointing a local team that we can interact with. We don't have that at the moment. I would like control over that. We don't have it, and in part, there's always and even within my own team, I don't have that sort of control over the entire team. I'm the clinical lead, but I only line manage one person. Out of that, they're all then because it's they're all based in different departments. They're all line managed by different people. So they're in terms of control, I don't really have any other than the assumed authority of a clinical lead medic, which does tend to mean things are on my plate. So I would actually like my team to take more control of the things that affect them and talk to each other without having to involve me. Not everything needs me, but they do tend to cancel meetings if I can't make it. Which but so I'm trying to shift that out at the moment. But I think the big thing for us, if we had really good working relationships with local teams in place, a lot of the care will become a lot easier. Okay.
Otherwise, I'll ask all the questions. Excellent stuff. And obviously a nice simple question challenge coming set this afternoon. So the one thing I want to say before Chris takes over, I will do the 1 minute VSM, because there are some people who haven't come across the VSM before, or one or two. So basically, an organisation is made up of a bit that does the stuff that the organisation exists to do, like delivering healthcare or whatever. A bit that seeks to regulate or control that. A bit that seeks to create its future, and a bit that seeks to argue about the difference between today and tomorrow. Okay, so VSM is a way of thinking about an organisation in terms of its ability to remain viable, to remain sustainable in the long term. So for those of you, that's the shortest ever version of the VSM that I've ever been able to come up with. Great, thank you.